Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
There's a 30-year-old builder who fell from a garage roof earlier today, falling approximately 10 feet, landing on a concrete driveway onto his left leg. He was seen in ED and I was asked to see him because they're worried about an open fracture because there's a wound over the lower leg near to the fracture site. So I went to go and see him, and he had an isolated injury to his left leg. The emergency department had done a full primary survey and cleared his C-spine.
Great, and that's obviously very important that even though an open injury, a suspected open injury is very interesting, we need to make sure that the patient from a systemic point of view is fine. So the full ATLS, Advanced Trauma Life Support approach to these sort of patients. So, and did you do a secondary survey?
I did, yeah. So he didn't have any other bony tenderness. It was an isolated injury to the left leg. I checked his C-spine again. He had normal, pain-free range of movement of his neck, no spinal tenderness.
What did he fall into?
So it was a fairly clean area. It was just a concrete driveway, and he just landed awkwardly on that left leg.
Good. Okay. And then what was your assessment of his leg?
So if you've got any fracture, you need to assess the neurovascular status of the limb. So distally, you're checking sensation over the different cutaneous areas of innervation in the foot. So in the foot, you're checking on the dorsum of the foot, there's the superficial perineal, and in the first and second web space of the foot is the deep perineal that you can check there. And you want to make sure that they can wiggle their toes, dorsiflex and plantarflex their foot. It's going to be painful if they've got a fracture, but you want to make sure there's not pain greater than what you'd expect, because that would make you think that there could be compartment syndrome. You'd want to check the pulses, the dorsalis pedis pulse on the dorsal aspect of the foot, and the tib post pulse just behind the medial malleolus, and just generally looking at the foot, making sure that it's a normal color, that the foot's warm and has a good cap refill, which you can check on the nail bed. A good place to check for cap refill, because then you don't sort of rely on looking at blanching in the depending on the colour of the skin. Looking at the wound itself for this sort of open fracture, one of the things that you start to notice is that open fractures tend to ooze a lot. You often see little grazes and things near to a fracture, but a giveaway that there is an open fracture is that the wound keeps on bleeding, and that's because bones bleed. And so if there's a communication between the fracture and the skin, it'll tend to keep on oozing. The important thing for that is then taking pictures of the wound to send to the plastics team, and then you need to cover the wound with a saline soaked gauze just to protect it for when then a splint or a back slab goes on. And every time you repeat something, so every time you manipulate the limb or put a back slab on, you need to make sure that you're reassessing the neurovascular status of the limb and documenting that clearly. Explain to the patient that you'll be taking a photograph, and we use a secure app. You need to make sure that when you're taking the photo, try your best not to get the patient's face in it. These photos get used for teaching or research purposes, so you need to make sure that the patient's aware of that and that they consent to that. You mustn't use your own device. So when you're taking a picture of a wound, you can't take it on your phone. You can use an app within your phone that is a secure app, but the image must not be saved to your device at any point, even if it doesn't contain any patient identifying features. That's still a breach of patient confidentiality to have a photo of them on your telephone.
And most plastics departments or emergency departments will have a departmental camera that they will use for these sort of photographs, and they're all encrypted and they're uploaded via an encrypted way. If they don't have the access to an encrypted app, which we are fortunate to do, but otherwise there's a departmental camera that is used, and only that camera is used.
So the emergency department have done some x-rays already, which have demonstrated a fracture of the tibia at the sort of junction between the middle and distal third of the tibia. and as well the distal fibula. He was very tender over this area, as you would expect. There's a significant amount of bruising, not very much deformity of the limb. It was looked like a fairly normal limb, but there was a bleeding wound on the anterior aspect of the shin.
Great. Okay. So there's a wound. It's broken through the skin, and we think that's quite close to where the fracture is. This is an open fracture until proven otherwise. What was his neurovascular status like?
So he appeared to be neurovascularly intact. He had good dorsalis pedis and posterior tibialis pulses.
Good. And how big is the wound?
So it was about a centimetre, probably, sort of slight curved wound. There's a picture of it here.
Yeah. So one of the things here, so we can see, obviously see the wound, but actually the zone of injury is going to be far greater than that. So how big was the spreading of the contusion, the bruising?
So the bruising sort of spread a good 7 or 8 centimetres around that area. I mean, there's quite a lot of bruising around that wound.
So there's two things that I'm concerned about this, because it looks quite swollen as well. So would you be concerned about compartment syndrome in somebody with an open injury?
Yeah, I think you still be worried. I mean, it's a sort of mid-tibial shaft fracture, so the mechanism would fit with developing compartment syndrome. It's a high energy injury, and although there's only a small wound here, there's still a significant amount of soft tissue injury below that.
Yeah, it's a low velocity but high energy. Okay, so we're concerned about compartment syndrome. I'm worried about the wound. This is an open fracture, so we need to act fast. So there's a few things that I want to know that he's already had, either that the emergency department have given him or that you've given him.
He has been started on broad spectrum antibiotics. Our trust guidelines are comoxiclav IV, so he's had a dose of that. He's up to date on his tetanus jabs, but he's been given a booster of that as well. So I've taken this photo and sent that to the plastics team, and the emergency department have put him in a back slab.
It's been clean, stabilised, photographs been taken, and it's been covered with a saline soaked swab, and put in a back slab. Okay, great. The plastics team are aware of him. Have you spoken to the orthopaedic team as well?
My registrar's seen it, and the consultant on call has been made aware.
Good. Okay. So you may be aware of the BOAST guidelines, the British Orthopaedic Association standards for trauma. They're guidelines for management of open lower limb fractures, which were devised by orthopaedic and plastic surgeons together, and they've evolved over the years. And the main difference between now and 10 years ago is that these fractures go straight from the emergency department to the hospital, where there is orthopedics and plastic surgery combined service is available. How would you classify this fracture?
So open fractures can be classified using the Gastillo-Anderson classification, which grades open fractures based on the sort of amount of soft tissue injury, so the size of the wound, the amount of contamination of the wound, and also the level of comminution of the fracture. So grade 1 is a wound that is less than a centimetre. It's a fairly simple fracture pattern, and there's no contamination of the wound. It's fairly clean. Then grade 2 is a bigger sized wound, so I think it's about 1 to 10 centimetres, with sort of moderate soft tissue damage. There can be some contamination and comminution of the fracture there. Grade 3 is extensive soft tissue loss, a sort of big open wound, with quite a lot of underlying soft tissue damage, severe comminution of the fracture, or severe contamination. Sort of marine or aquatic contamination is very important to know about in these fractures.
Yeah, so that changes the severity of the injury. If it's in a marine environment or farmyard, anything where there's abnormal organisms, not run-of-the-mill organisms that are going to be sensitive to our standard antibiotic prophylaxis, they require urgent debridements and washouts. So how do you think this is going to be managed?
So plastics assess the wound and the degree of soft tissue damage, and determine whether or not they could use primary closure for this wound, or whether or not it might need a skin flap to help cover the soft tissue sort of deficit. So normally prior to these operations, you would have a CT angiogram to sort of look for areas where one could take a flap or pedicled flap with a blood supply.
You're looking for suitable vessels.
Yeah.
And are they going to decide that in isolation, what they're going to do?
So that'll be with discussion with the orthopedics team. In a very comminuted fracture with a lot of soft tissue injury, you can apply an external fixation device just to stabilize the fracture.
Do you think this one needs it?
I'd say probably not. It's not comminuted.
I would agree with you.
So you could probably just go straight for sort of definitive surgery, and probably would be with an intramedullary nail of the tibia.
Yeah. So I don't think this needs an external fixator to stabilize it. It looks as though it would be quite stable in an above knee cast, because we need to immobilize the joint below, which is the ankle joint, and the joint above the knee joint. So it's going to be an above knee cast, and then that will then get referred and transferred to the orthoplastic service, and then there would be a combined orthoplastics list. And this is one of the key aspects of one of the main developments of the BOSE guidelines for these management of these fractures, is that it is a combined approach, and it's not just one person saying, "I want to do this," and then leave it for someone else to find later. So they would debride, or what is now called a wound excision, where they excise any non-viable skin or muscle or soft tissues around the wound, so that everything that is left is going to survive. What you don't want is for tissue that's been so badly injured to remain and then die away slowly, so that whatever fancy fixations taken place is then left exposed to the world, and it's going to get infected, and worst case scenario, the patient's going to lose their leg if it gets uncontrollable infection that infects the bone and is non-salvageable. So that's essentially what we're trying to avoid, is somebody losing their leg because there's not adequate soft tissue cover. There's a very nice adage that a fracture is merely a soft tissue injury with a underlying broken bone, and it's the soft tissues which will determine the long-term outcome. If the soft tissues aren't looked after, no matter how good your fracture fixation is, it's going to mean nothing.
Can you just put some context about how significant this injury is by describing what the treatment would have been pre-antibiotics? Maybe you didn't work then, I did.
I
mean, well, this would be an amputation, or it would be a high risk of dying, and the only real way of salvaging it, in the early part of the last century, would be to do a primary amputation, because it would be infection that would kill you. And it's just to put it in context how far we've come in treatment. Is pre-1946 or thereabouts. It was completely different. So it's a soft tissue and infection that's the thing that defines this injury. Yeah,
and I mean gangrene was pretty rife, and many people in the First World War lost their limbs because they were shot and they didn't have appropriate antibiotics to prevent gangrene setting in, and so amputation was pretty standard. Good, but we've come a long way since then.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at thegrandacademy@btinternet.com.